so much. Aloha, everyone. Aloha. I'm thrilled to be here. I'm gonna fly through these because I really am most interested in taking your questions, but I did want to give you a little bit of an overview of how marijuana research is conducted in this country and what are some of the barriers to doing this work. So let me just share with you. Brian did a great job of giving you guys some of my background, but let me tell you a little bit more about myself. I've lived in Scottsdale for 30 years, and I practice internal medicine and psychiatry. So basically I do primary care for seriously mentally ill patients, and I do it all over telemedicine. So even while I'm here on the island, I get to see my patients over video conferencing, which has been terrific to be able to stay in touch with my patients and get to be on such a beautiful island. So I have taken care of military veterans now for about 20 years. I started at the Phoenix VA hospital during my residency training was when I first became enchanted with the veterans community, and I love their candor, their honesty, and we developed a really deep fondness for each other, and eventually that culminated in me trying to design a study around veterans looking at new treatments for PTSD, which I'm going to talk to you about. But sadly, I was a faculty member at the U of A Medical School in excellent standing for about a decade until I became the principal investigator on this research, which is the most controversial research at the university, looking at whole plant marijuana for veterans. And that put me at odds with an administration that didn't value this work, that didn't want to see marijuana studied on their campus, that thought it would harm their federal funding. And so we were in conflict for many years over this, and finally we got fired. But the great outcome of that was we ended up getting worldwide media coverage for about a year after that, where all these outlets reporting on the injustice of and helping us shine a spotlight on the barriers to marijuana research. So I wanted to emphasize that I've never actually used cannabis personally, and that's just a choice that I've made because I want to go into this research without any preconceived notions about how cannabis works. And it's helpful for me to be able to say I'm a lifelong Republican who's never used cannabis. In Arizona, that is extremely valuable. So I hang on to that. But I also, it's good for you to know that I'm not part of the industry, meaning I don't own interest in dispensaries. I don't have financial interest in cultivations or any of that. And I don't even write recommendations for patients. I'm just interested in the science. I focus on the research side. And I'm going to just give you a little glimpse of the trial we're trying to do. So this is basically, we're looking at 76 military veterans with PTSD, and we're going to be using 4 different strains. Oh, I'm sorry. Oops, sorry about that. Get that back in. Thank you, hon. Let's see. So we're going to be using, oops. Hold on. That's all right. We'll get this right back in here. So we're going to be using 4 different strains of whole plant marijuana. And after getting tossed out of the University of Arizona, we ended up with a partnership with Johns Hopkins University. So I'm actually splitting the protocol between the site in Baltimore and my site in Phoenix. And we also have a partnership now with University of Pennsylvania, with UC Denver, and also with my sponsor, MAPS. So that's that'll give you a good sense of what's happened. So it wasn't, even though the study was very radioactive after getting terminated from the U of A, the fact was that there were some universities around the country that had the courage to partner with us, and so that was a good outcome. So. Oh yeah, I just couldn't remember what the next slide was. Let's see. So anyway, I'll just tell you about basically the reason that we're interested in studying PTSD is because we have a serious epidemic of veteran suicide in this country, right? We have 22 veterans each day that are killing themselves here, and we don't have any good treatments for them. We have one of the things that I'm going to share with you is really right now there's only 2 medicines on the market that have been approved for PTSD, just Zoloft and Paxil, that's it. So, if any of you have been on these meds, you know how tough they are to tolerate. They've got a lot of side effects. They've got tons of drug interactions when, these vets and other PTSD patients end up getting put on tons of different meds, all interacting with each other. So this has been a big frustration. The veterans come home from service and they just want to reintegrate into their community, and they end up getting pummeled with all these prescription meds. And they can't think, they're sedated all the time, they have all this weight gain and sexual dysfunction, and then suddenly they are completely non-functional, they can't even enjoy being part of their family. So
I'm not sure where you want to go.
Yeah, that's perfect. Yeah, thanks, Brian. So this is, after getting tossed out of the university, we ended up with a $2.1 million grant from the Colorado Health Department, which was a big achievement because it was the first government money that we'd ever gotten to actually study the effectiveness of marijuana. It's really unusual that you can find any government money except money to look at harmful side effects of marijuana, what we call safety studies, right? The good thing was that the Colorado Health Department got allocated about $10 million a couple of years ago to try to study only the effectiveness of marijuana. So they had, and hopefully this will happen in Hawaii too, where you'll see through your medical cannabis program, you'll hopefully start to generate a surplus. And that surplus could be used to promote research like this. So what happened was in Colorado, they generated a $13 million surplus from their medical cannabis program, which they decided to take $10 million and allocate to all of these projects you see here. So everything from studying does marijuana work to reduce opioid dependence, right? The heroin epidemic and our dependence on pain pills. Does cannabis help with inflammatory bowel, like Crohn's disease and ulcerative colitis? So we're going to be studying all these areas, and hopefully in the next 3 years or so, you'll see published data on all of these illnesses. But what I wanted to show you is the reason that we're fighting so hard for our study is because it's the first and only randomized controlled trial in the country looking at whole plant cannabis for PTSD. So it's really important to get this thing, to get some of these questions answered. So what I wanted to talk to you about now is just the history of cannabis in this country, which some of you may know quite a bit about, but I wanted to just highlight a couple things that I think are valuable to remind everybody. So, our nation's formulary was the pharmacopoeia back in the 1800s. This is the way we decided what medicines were good for what illnesses. And in that pharmacopoeia, even in the 1850s, they already identified that marijuana was helpful for things like opioid addiction and for alcoholism and all these things that you see listed. So this is just a partial list, but it was amazing that people in medicine back then saw that cannabis was helping reduce opioid dependence, that it was useful as substitution therapy for people hooked on pain pills. And so that was pretty fascinating to me. But then on top of that, we got this drug czar, right? They got appointed, and Harry Anslinger ended up, creating reefer madness, which we all know has done, a lot of harm to our drug policies in this country. It seems to color all of the thinking now about marijuana being, a deeply dangerous drug. And so you'll see here that, this is some of the quotes from Harry Anslinger. He made a lot of very racist statements that continue to influence the way drug policy is organized in our country. So, but then this continued when Nixon in 1970, when he signed the Controlled Substances Act. Suddenly we have this situation now where marijuana has been added. We create a scheduling of controlled drugs. And suddenly marijuana is lumped into Schedule 1 with all of these very, very toxic drugs. You know, like if you've ever seen the list of controlled substances, let me just give you a glimpse of it here. So the problem with this list is it's defined by the DEA, right? So we have the Drug Enforcement Agency decides on the medical benefit of controlled substances in this country. How would they know much about that? We're not sure, but this is the wisdom of drug policy here, where the law enforcement professionals have decided that marijuana belongs in Schedule 1 with all these psychedelics and other, much more toxic drugs. Yet Schedule 4, the DEA defines as drugs having very little abuse potential, not addictive. And then you see drugs, like Valium, Ativan, Xanax, drugs that we know have huge street value and are highly addictive. So I think all of us believe that this entire controlled substance schedule needs to be reorganized by people who actually, by medical people who know the properties of these drugs. So, and we all saw when Sanjay Gupta came out in 2013 with this incredible, these really powerful statement about marijuana. This was a huge help to us when he pointed out the fact that, marijuana, he said, I mistakenly believed the DEA when they assured us that marijuana was, incredibly dangerous. He said, I assumed that they really had sound scientific evidence to defend their thinking that it belonged among the most dangerous drugs. And then he goes on to say, but they didn't have the science. They did not, and we have been terribly and systematically misled in this country to believe that marijuana belongs, it doesn't have medical benefits. So this was really, really powerful and has helped us tremendously to try to, to begin to have a dialogue with electeds about the fact that there is medical value here to this plant. So I became interested in this issue because my veterans started coming to me in my medical practice saying, hey, this plant has been helping me with all of these different symptoms. And I was, hugely skeptical because I'm trained in a really conservative medical model where we don't value anything as medicine unless it's been put through the FDA process. So I just couldn't even fathom what, I thought these guys are just drug seeking, and I was very dismissive. Of course, now I'm very, I regret that very much because these veterans were trying to teach me, and I was not open. I was so blocked by the medical training that teaches us basically that marijuana is a very toxic drug that's highly addictive. So I couldn't get. Finally, the vets just kept. They felt because obviously once you've had relief from this plant, you want to tell that story, right? You want to talk to people about it and let the world know. And so these veterans were very fervent. And kept, for years trying to open my mind to this. And finally I said, there's got to be something here, because it wasn't just the vets, right? It was all of their family members, all this collateral history from spouses and children. Children were like, I got my dad back. It was so stunning to me. So, and then I became acutely aware of the suicide epidemic among veterans because in my own practice, I've lost a lot of veterans to suicide. In 20 years, I can't count now. I've lost count on how many vets have killed themselves. But the worst part about this is that we don't even have legit data, right? Like we talk about 22 a day. That's even, we all know that that's a low estimate, right? Because all of the veterans in my practice who've ended their life were all labeled as accidents, right? If you take a prescription drug overdose, the coroner's office will 99% of the time label that an accident. I had a veteran recently who drove his motorcycle into a barricade at 100 miles an hour. He had a suicide note at home, and I knew this patient was actively suicidal, and the coroner's office still labeled it an accident. So you can see what we're up against. This data is not accurate. The coding is almost never accurate. So this number, 22 a day, is actually probably shockingly much higher than that. But it's already a horrific number, and this is the data that our own VA system put out. They published this last year. So we now, have documentation about the fact that, and I'm really curious because, you think about in Canada and in Israel, where veteran community gets not just legal access to marijuana. All the vets get, their monthly supply of cannabis there if they want it, but it's fully subsidized by the government. So I've sat with veterans in clinics in Canada and Israel where they're picking up their allotment of cannabis, and they can pick it up in all different formulations. In Canada, they can pick up to 10 grams per day. So they can get up to 300 grams of cannabis each month. And it's all sponsored by the government. So you wonder, what is it about our government that does not allow the existing science to persuade them? Why is it, are these governments in Canada and Israel just negligent? That they're so reckless that they're allowing their vets to use this? I don't know. So, this is what is really, it's really, tears me up all the time, is that when we look at the prescription drug overdose problem in this country, and then we look at the fact that we only have these 2 meds available to treat PTSD, and on top of that, the other meds that I have to use are so disappointing. This is a presentation that I gave at Walter Reed Hospital recently, so it's important for you guys to know that the biggest military hospital in the country, Walter Reed, invited us to come and present 2.5 hours of marijuana content to their military doctors. And what I was trying to show them was, look, when Zoloft and Paxil fail, this is what I'm allowed to do. As a psychiatrist, for instance, I can utilize all of these medicines on these lists. You see all of these antidepressants from all classes, all of these sleep meds, just piles and piles of prescriptions that I'm allowed to give. None of these medications have ever been tested for PTSD, but I'm allowed to use them. So that's why you can see how quickly all of these mood stabilizers, that we use for bipolar disorder, all of the benzodiazepines, all of the antipsychotics are fair game for me to utilize. So you can see why our veterans community becomes so demoralized. They come back and we can't find a way to fix them, so we just keep pummeling them with all of these prescription meds, and none of them really do much, right? But then you look at a plant and you say, this plant is so complex. This plant, this is what I wanted to point out. Veteran community has a 33% higher rate of prescription drug overdose. So this is incredibly depressing. Part of that is because of us in the medical community. We're the ones who give the veterans these pills, and they use that as a weapon against themselves eventually. So this was a big breakthrough last year. Remember, if you guys saw this JAMA article came out, and very mainstream medical journal, talking about the fact that in the 23 medical marijuana states, so in all these states that have legal cannabis available, that there is a 25% lower opioid overdose death rate there. And if you dig deeper into that article, you'll see that each year that these states had a comprehensive medical cannabis law, like what you're about to implement, what Hawaii's soon to implement here in the next year, you see that the opioid overdose death rate continues to diminish year after year. So each year the program takes hold and more patients learn about cannabis as a potential treatment for pain and for anxiety and all these other things that anxiety is not a treatable condition here, but if you think about 9 different qualifying conditions here in Hawaii, right? So you're going to have patients and caregivers and physicians who are going to be able to finally utilize this plant to treat all these myriad of conditions. So let me talk with you. This is a great illustration that one of my patients put together, and I love to use this because I think it's so accurate portrayal of what our veterans are drowning in pills and pill bottles, and they end up discovering cannabis. You know, here in this case, he discovers a rolled cigarette. But this is, you know, the reality is that, you know, veterans are finding cannabis life-saving, and we need to understand why. We need to understand what strains are best for what illnesses, and how we can finally help curb this epidemic of veteran suicide. So I think what I'd like to do is leave you guys on this picture because I think this is so powerful, and I want to now be able to take your questions and have more of an interactive dialogue. So if anybody has questions, just throw your hands up and let's see if anybody has it. Yeah, go ahead.
I'm interested specifically, I have in the biological mechanism. I have a family member who has HER2-positive metastatic breast cancer.
Yeah.
And she's gone through all the radiation, chemotherapy, surgery, and now she's at a place of maybe being able to look at a protocol like a Rick Simpson protocol.
Yeah.
And I guess one question I have for you is, how do you negotiate all the information that you do find, depending on where you go regionally or looking on the internet? I've talked to so many people on the phone who work in dispensaries, and there doesn't seem to be a consistent body of knowledge.
Can you summarize and repeat?
Yeah, sure. So he was asking about, you know, in terms of breast cancer, for instance, where do you access a legitimate body of knowledge about, you know, where do you get guidance for how to use cannabis for, in this case, for someone who's already been through treatment and wants to examine, so a high THC oil is what, when he talks about Rick Simpson oil, right, that's a very important breakthrough that this gentleman, Rick Simpson, really an inventor of one of the most interesting you know, oils that seems to have, you know, magnificent anti-cancer property, but again, has never been formally tested. So all of this is anecdotal experience that Rick Simpson has collected over decades now of making this. So I've traveled a lot outside of the U.S. trying to talk to patients about their experiences with cannabis, and many of them have had some really transformative experiences using Rick Simpson oil. And the good thing is, eventually it's not going to be called that anymore, right? It's going to be, you're going to have access to high THC oil here on this island through this dispensary model. So you'll be able to get this, but in terms of being able to find a real body of research that would guide you on how to use it, this is going to be the challenge, right? It's really what we're looking at here on this island and in any medical marijuana state is a process of self-exploration for patients. Patients are going to have to go through a process of trial and error, where they're going to have to, and hopefully no errors, but the truth is that that's the way medicine is in general. You know, the fact is, most of the prescriptions I give to patients, half of them don't work during the first trial or the second trial, and so it takes time to go on sort of an odyssey and find that right thing. But Right. So Brian just pointing out that, you know, in his case, he's made a commitment to provide consultation with medical professionals on site. So what they're going to be available to you guys to, you know, whether it's a nurse or a pharmacist or somebody who is going to be able to talk with you about the medical properties of each of these different formulations, whether it's vaporizing or tinctures, and talk with you and hope to guide you through that process, so it's not just such a confusing, you know, confusing morass of different information. But it's going to be tough. I mean, there's no question that because the government, we didn't even talk about yet all the ways that the government has blocked this research. But the good news is that Brian is making a commitment to collect data from people here on the ground. So on the island here, you're going to have live data collection. As patients come in, they utilize a strain. We're going to be able to document their response to various strains, and then to be able to look at that in total and publish that so that people can see how various strains are working for illnesses. So that's going to be really important. Yeah, anybody else over here? Yeah, go ahead.
So the legislature is looking at a bill to authorize the University School of Medicine, Cancer Center, and UH Pharmacy School to do research and conduct medical trials. Is there anything specific the legislature should do and/or the state university should do to encourage medical research from your experience?
Good question. Yeah, so she's asking about how, what can the state do? Because obviously the research is unfortunately being blocked a lot, mostly at the federal level. But there are problems at the state level that are really, as you can see just by the way the University of Arizona reacted to this, there is a pervasive fear among all state universities that doing cannabis research on campus will harm their ability to draw down federal dollars, that they won't be able to get federal grants. So you're going to see the same problem here, even in states like Colorado and Washington that have both medical and recreational. Still, those state universities are terrified of conducting even legitimate marijuana research, like FDA-approved research. They won't do it because they think it's going to harm their federal money. So you do have an opportunity here, because if your universities adopt a more progressive approach here, then you could become, this island or this state could become the mecca for marijuana research, because because all other universities are running from it. If University of Hawaii actually embraces it and is proactive about saying, we want this here, we want to be a home for marijuana research, and if you create a sanctuary for this work, then you could become the new, you could be at the forefront of the most important marijuana research happening in the country. And I think that that's a really good goal, and I know that Brian is committed to doing that. He's committed to taking a portion of the proceeds from the cannabis sales and plowing that back into research. Research is so expensive. I mean, our project, as you can see, the total project cost of a randomized controlled trial is $2.5 million. That's typical of any kind of randomized controlled. So that's why you can see, and there isn't government money available except that little bit of money in Colorado, and that's all been allocated. So now the question is, will your state, first of all, there's two things that the state legislature can do to create a conducive environment for cannabis research. One is they can make sure that surplus money from the medical cannabis program would be allocated toward research, that you would maybe create a scientific advisory commission here for the state that would kind of adjudicate proposals that come from your scientists here locally and be able to allocate money to that. Because right now, every state has a kind of a biomedical research commission where they take state dollars and they put it into different. The problem is that none of those commissions are willing to fund marijuana research. They fund everything else. They'll fund Alzheimer's, they'll fund cancer research, they'll do all that, but they won't come near marijuana research. So if your state is willing to do that and allocate, all you have to do is say, we want 10% per year of the surplus from your medical cannabis program to go into cannabis research through the Biomedical Research Commission here. That would be a big step. Then, if the universities would take the step to send out a letter to all of their faculty, different than what in other universities, the presidents have sent out letters saying, we are not conducting marijuana research ever. Even this happened at University of Colorado. The president sent out a notice to all the faculty saying, you will not do cannabis research on our campus.
Similar thing at the University of Hawaii.
Oh, they did do that, yeah. So that's the thing, is if you can persuade the university president here to change his attitude on that and instead adopt a really proactive approach. And maybe it's going to take, people, for instance, in this room, if you can somehow influence the university administration, or if you have a board of regents here or something that that you can go and testify and tell them about how you think that this is crucial. I mean, here you are, you guys are rolling out a really progressive medical cannabis law. This is probably, when I looked at this law, the letter of this law, I said, this has the potential to be the best medical cannabis state in the nation, because it's got a broad list of qualifying conditions. You allow for all different formulations of the plant. It's really wonderful. It's a great opportunity to do research and to collect objective data on how patients are responding to this. So if you could go and talk to the legislators and to the Board of Regents and tell them that we don't want to miss this opportunity. Right now, you're going to start seeing, many new, that you've got, what did we say, 15,000 patients on the, 13,000 on the registry now, and hopefully you're going to see that double and triple over the next year. So you've got a great chance to start collecting data from all of these people who can openly talk about their use of cannabis now. They don't have to live in the shadows anymore. They can talk in detail about how they're reacting to this plant, the good and the bad, right? We want to know everything about the plant. So that is the purpose of a university, in my opinion, right? Universities used to be the sanctuary of that kind of work. They used to take pride in finding a home for that kind of research when they knew, controversial research that couldn't be done anywhere else. But instead now we see all the universities running scared from it. So whatever we can do, and we will help you with that. Certainly I know Brian has relationships with lawmakers and university officials, and we intend to do whatever we can to try to build to forge partnerships with the universities here. But we need you guys too. We need the public to continue to put pressure on them, because otherwise it's just us, begging. So, yeah.
I've got a question.
Sure.
Have you ever heard of anything called CDR Med by Zelda's Frontier?
Yeah, I've heard of it online, but I don't know much about it. Do you know what it is? Can you talk about it?
Well, they had a presentation they did at the Cannabis Expo.
Ah, okay.
Now what it looks to be is like, you guys have seen the physician's desk reference, right? The big red book that all the physicians, but what they're doing is they've automated this process basically for that reference, but using cannabis as the treatment. And all they're right now they're working out in California. I know they have patients there where they're taking these patients, like I walk in, they say, okay, you've got MS, you've got, diabetes, you've got IBS, you've got all these things.
Yeah.
And they take, using street names at this time.
Okay.
And they will match patients and dosages and start you out. They actually then have a baseline, someplace to start with.
I see.
And then work it. And it's called CDR Med. And by, like I said, at Zelda's, you might have heard of it.
Okay.
This is Zelda's Frontier, so I think it's an option of that.
Wow.
It's basically how you'll collect the information.
Yeah.
Is what I'm talking about. I'm not talking about a.
Yeah, is it an
already
app?
Automated.
Okay.
They've already got. They have patients in there already.
Okay.
And so I mean, I've only seen the one presentation myself.
Yeah.
But it's an absolute solution.
Yes.
To collecting in a
That's
logical,
right.
analytical fashion, profiling your patients,
That's
being
right.
able to say, okay, let's start with this dosage. And when you start, that doesn't mean that's going to work. Cannabis is like all medications. You try this one, see how this
That's right.
does.
You got
You
it.
might have to try this regimen. Maybe you don't smoke it. You gotta have a tincture. You gotta have a capsule with something in it. But this, I think this is a great. I think I would like Manoa Botanical Gardens to also look at it and see about the potential of using. I mean, why reinvent the wheel?
Yeah.
If
No.
you go to a university and say, look, here's people, here's a methodology. Here's something that's actually in use somewhere.
All right, right. I love that idea. I think that she brings up a really important point that, we're going to see all kinds of innovation like that happening as we see, prohibition finally lifting on medical cannabis. We're going to see the opportunities like that to create apps and all kinds of new software that will allow us to collect data. But what's even more crucial is being able to collect data on lab-tested cannabis, right? And that's what the law here is going to allow you guys to finally have, you know, to allow our patients here on the island to have lab-tested cannabis that we can then correlate. So instead of saying sour diesel helped my, you know, my agitation of my whatever, that, you know, then then we will be able to actually say, you know, this ratio of THC to CBD to CBN was able to benefit my illness. So
If you use something like this, you can get away from street names eventually.
That's
because
right.
Then you can work with more genetic profiling and terpene.
That's
So
right.
our plan is to try to avoid using street names in our dispensary if we're awarded a license. I have a question. I meant to ask this at the beginning. Who here currently has a 329 card?
Is that a blue card now?
That's a blue card.
It's white.
It's white. It used to be blue, now it's white. Okay, so we have a handful. Who here are caregivers?
Oh, good, you guys.
All right, fantastic.
Good.
Who's here that this is the first time they've ever been in any kind of medical marijuana presentation? Wow.
Good, you guys.
So we have a really good
Yeah,
representation. Who here is a physician or a medical professional?
Good, you guys.
Physician, nurse, someone. Who here is currently certifying patients of those in the medical community? One. It's part of the problem. It's one of the problems that we're trying to solve. It's one of the reasons why, back here, it's one of the reasons why we brought Dr. Sisley out to help educate the medical community so we can get more physicians and potentially APRNs if that legislation passes. So Bella. There's a couple questions. The first one here and then the second one there.
Yeah,
Go ahead.
Alan.
Thank you. Is there any reason, I understand that universities could put their federal funds in jeopardy, and I understand that, because that's how the game goes.
Sure.
Is there any reason why a private laboratory could not provide and can conduct and be an armature for this type of research?
Yeah, there's no reason why you couldn't. Yeah, she was asking, she understands why universities certainly are fearful of doing this work, but why is it that a private lab couldn't do it? And truth is that there's nothing preventing a private lab from creating a randomized controlled trial and implementing it. The big obstruction right now is money, because it's so costly to do these studies. And of course the study drug, because getting, you know, for our study, we have to buy marijuana from the federal government. So I can't buy marijuana from Brian or any other license of, you know, eventual license holder here, because we are not allowed, this is not a federally legal supply of cannabis here in Hawaii or in Arizona or anywhere. So the only legal supply is at University of Mississippi, and many of you have seen the grow out there. It's pretty depressing. They only have a few strains available. They don't have the strains that investigators are requesting. They don't have it available in a timely way. We had to wait 20 months for our marijuana. Now we're waiting on the DEA to approve the protocol after we've already been approved by the FDA. 4 different IRBs and the Public Health Service. Now we have to wait for the DEA, which is, you know, so just so you guys have a sense of what the timeline is to do marijuana research in the country, we submitted the study design to the FDA back in 2010. We got approval from the FDA about 5 months later. So we had approval in April 2011 from the FDA, and here we are 5 years later, still have not enrolled our first veteran in the study. So this is incredibly shocking to me that our government, when we have an epidemic of veteran suicide and we have vets suffering so profoundly from PTSD, that you would think the government would expedite research like that. And instead, they have stonewalled this at every turn, and we still don't have any timeline for when this study will finally get started. And it's just I mean, I think all of us should be, should be concerned about this as taxpayers, that we are seeing massive amounts of taxpayer dollars going into safety studies on marijuana, looking at harmful side effects and addiction potential. Where is the funding to look at efficacy? Why is it that we keep plowing all this money into the DEA to help to continue to impede this work? So one of the things that I was going to talk to you about, but I didn't want to, bore you with all this, but if there's one call to action that I have for you today, it's to help us end this DEA monopoly, because it is outrageous that I have to buy really substandard, thank you guys. I appreciate that, because, to have to buy substandard cannabis from the DEA through University of Mississippi is just it's one of the final barriers to marijuana research. Once we end the DEA monopoly, so that I would be allowed to buy cannabis from any expert grower in the country. This is it. So the DEA, we call this the NIDA monopoly. So the DEA has licensed this facility in Mississippi since 1968. NIDA has a government-enforced monopoly on the only federally legal supply of cannabis for studies like this. So the only studies I can do here in Hawaii using Hawaii-based cannabis are observational studies, which we know, in medicine don't have the influence on our colleagues. The medical profession wants to see randomized controlled trials. And you can't do that on state level marijuana. You can only do that with federal government cannabis. So this is a really big problem. And you can see the pictures here. This is the cannabis on the left that Mississippi sells me. It's, this one of my colleagues dumped out the content, so you can see how, this is, so a lot of people in medicine would argue that this sabotages the study from the beginning, right? And you're forced to use this, when really that's what we want to use, right? It's just the flowering part of the plant, where we know, has the maximal therapeutic benefit. So, this is one of the things that we're hoping if we all focus on ending this DEA monopoly so that we can finally license other expert growers in the country, that would be a really important effort. I'm sorry. Oh, okay, you first, huh?
Okay. When dealing with veterans, what I found one of the biggest preclusions from them taking on cannabis therapy to start with is fear that they're going to lose their benefits from the VA.
Yeah, right.
So if you could say something to those vets, what would you want to tell them regarding that? Because that seems to be, truthfully, it is the single most effective thing that I've ever experienced, period.
Is that right?
And it's very difficult to deal with the fear that you might potentially lose your only source of income.
That's true.
Or something.
That's true.
The same way you lose an honorable discharge.
Yes. Yeah.
There's a veteran who was on a whole lot of
wow.
meds.
Oh, this is.
Can I say something about that?
Let me.
So the benefits can be reviewed. When they're reviewed, you get benefits based on certain criteria. If you're cured from whatever, you don't have the same presenting medical problem that you begin with, so you should lose your benefit and you should go out and get it work.
That's not quite what they're having experience with. They're being denied medication because they're using cannabis. And they're classifying it as a drug-seeking behavior.
That's right.
So the VA has come up with an opinion that in states that are legal, they're not going to. They used to say if you come to the pain clinic and you want to use marijuana, that you just show you're a druggie, so we're not going to treat you in the pain clinic. They've come up with a ruling that says where it's legal, they're going to ignore that and treat you anyway.
That's
I have a copy of that paper.
Yeah, you know what she. I know what you guys are doing. There's a VA directive called the 2011-004 that talks about, it's supposed to be a protection for vets. Her question was, what do we do with how do we reassure veterans that if they choose to get a medical card, how do we protect them from losing first of all, their financial benefits, but also their ability to access other treatment at the VA? And this has been a real problem. She highlights a really critical issue, is that a lot of vets around the country have been terminated from their pain programs. They are not allowed to have access to opioids if they have a positive urine drug screen for THC. And it is a huge, huge concern for them, because a lot of vets have successfully learned to use some opioids and some cannabis, and have been able to cut down dramatically the amount of pain pills they're on by using cannabis adjunctively like that. So we want to be able to protect, to create an environment where veterans are protected. But sadly, this VA directive, even though it's called a directive because every VA hospital is required to adhere to this. And the directive says you are not allowed to fire a veteran who is in a legal medical cannabis state and has a medical card. So, but what happens is that when there's a saying that if you know one VA, then what is it? You've met one VA, then you've met one VA. It's not like one VA doesn't represent all the VAs. Every VA is completely different, how they treat their vets, how progressive their thinking is. And so there are certain VAs around the country that have completely ignored this directive and will fire the veterans for one urine drug screen that's positive. They end up terminating them, cutting them off all the meds, not just pain pills, but benzos, any controlled substances. So that can be really, yeah, it's right. Yeah, so it can be really, really harmful. And you're pointing out something that's essential, that hopefully here on this island and all the islands in Hawaii, hopefully we can persuade the VAs to adopt a compassionate approach that fully acknowledges the law here in the state, and that encourages the VA to at least all right.
I think we had a question
Okay,
here.
yeah.
I just want to say how wonderful it is to hear you. I'm a psychiatrist,
Oh, good.
2 blocks away in private practice.
Wow.
I found out about the talk last night.
Oh, good.
So
Thank you for coming.
I want to hear what you have to say about stimulants and what you've heard about Ritalin and Adderall abuse during deployment.
Yeah. It's interesting you bring that, because I don't have, he's asking about the stimulant effects in the veteran population specifically, or just in general? In general, yeah. But stimulant effects and how it interacts with cannabis. Is that right? Okay, so this is a really interesting, because one of the things that we see, especially in the veteran population, is that we do use an excessive amount of stimulants with vets, because usually we're trying to overcome all the bad side effects of these other psychotropic meds, right? So when these psych meds end up making them sedated and totally obtunded, we try to give them stimulants to try to jack them up again, and it's been really frustrating for them. But it's interesting that you bring up that there's a potential therapeutic synergy. Is that what you're saying? That stimulants may have potential good interaction between stimulants and cannabis? Is that the question, or?
I view PTSD as a hyperadrenergic
Yes.
problem.
Yeah.
And Adderall and Wellbutrin, which is a ketoamphetamine,
Yes.
it's not well known that it's an amphetamine, Wellbutrin. I see it as worsening PTSD, so I get that's off of Wellbutrin
I
as
see.
often as I can.
Good.
And so the relationship of explaining to them you need less adrenaline in your body.
Right.
And I don't know how to say from a research base, what can I say in terms of marijuana will lower your adrenaline?
Right,
I
right.
want to take it offline because it's
Yeah, I see what you're saying.
technical and hard.
Yeah, I see. He said, you know what? I'm gonna talk to you more about that after, because there isn't any data right now for sure. That's one of the problems we have, is we don't have any good answers on how cannabis we don't even have answers on how it treats PTSD, much less how it could, work to help people reduce their stimulants and things like that. We have some, initial survey data that suggests that patients are coming off opioids, stimulants, benzos, using cannabis. But I want to talk to you about that more. So let me come back to you on that. We'll get to, yeah.
your association and affiliation with John Hopkins you had mentioned earlier.
Yeah.
Are you familiar with Dr. Remington Nevin, one of the leading advocates in the nation in the war against mefloquine and Lariam, the anti-malarial drug that is prescribed to veterans for decades and has disastrous effects on the neurological system of many people.
Yes, yeah. I am not aware of it. I mean, I'm not aware of the
Same type of effects that severe PTSD symptoms and aspirated symptoms of the laundry list that displayed.
I have not, and I don't know that researcher that you mentioned either, but I'd like to hear more about it. If you have that info, I'd love to get that from you. Yeah, let's do that. Yeah, I appreciate you bringing that up. Yeah, yeah.
I have a severe arthritis condition, very painful.
Yes, sir.
Managing it with corticosteroids, but when it doesn't work, extremely painful, and I'm allergic to all aspirin-related products. Leave me with just the narcotics.
Yeah.
And I don't really want to take those.
Yeah.
How effective and how dangerous is it to use the marijuana for pain management?
Yeah, well, it's certainly, if you compare opioids to cannabis, the toxicity of opioids is obviously considerably more damaging. So I would say, typically what we talk to patients about is that cannabis, the toxicity is really low. It has a very mild side effect profile that is real, and in terms of, for instance, addiction potential from cannabis versus opioids, I would say that generally cannabis is not much more addictive than a cup of coffee. If you look at the addiction rate of caffeine versus cannabis, they're very similar. It's about 9 to 10%. So I would say it is certainly worth it just because of what you're describing, where you're not able to take aspirin-related products and you're stuck on opioids. I would definitely say that folks like you are a great candidate to explore cannabis as a adjunctive treatment, as a kind of supplementary.
How effective is it at managing pain?
That's right. He's asking, how effective is it at managing pain? That's the problem, is some patients get extraordinary pain control and some don't. So each patient has to be, that's why it's so important what Brian was describing, the consultation, where you are able to talk to someone at a dispensary and kind of go through this process of figuring out, because for instance, there are certain strains of cannabis that might work and other strains that don't. Remember, we talk about marijuana as if it's one plant, but there's hundreds of phenotypes of this plant, and all of them have different clinical properties. So we don't know, we won't know when you first come in what strain is going to be best for managing your pain. We're going to try one that we think is best, that has worked best for other people with pain, but it may not be the first one you try that works. So that's why it's the old adage of start low, go slow, try a little bit of one strain, see how it works. But you would be a great candidate to explore this, because if there's any way that we could help you, cut down your opioid dependence, we'd certainly love to explore that with you. So, yeah.
I have a question about guys' current topic. Are you guys doing research and studies on specific cannabis, different CBD profiles, and like you said, arthritis versus PTSD or back pain?
Right. Yeah, well, that's what we hope to do. So Brian said that he's going to be hoping to cultivate over 10 different strains within his first year of being operational. And what that will allow then is for you to experiment with these different strains. And look, in our study, we're going to be looking, here you can see we have 4 different phenotypes of marijuana that we're examining. So we have a placebo control, we have a high THC arm, we have a high CBD arm, and then we have a 1-to-1 ratio of CBD to THC. And yeah, it's a weed bag. That's okay, don't worry. But basically, you know, those are the kind of studies that will help us start to pinpoint what strains are best for what illnesses. But as you can see with our study, you know, the fact that the study's been blocked for 6 years doesn't bode well for waiting for the government to greenlight studies is going to be really hard. So what's more important and what's going to get you immediate data here on the island is letting people start, you know, getting their cards, purchasing cannabis through a dispensary, lab-tested cannabis, so we can start to understand how, you know, patients here are responding to various strains.
I work in industry, and if you would come to me and says, hey, I have arthritis, a lot of people are being turned off because they're giving them the wrong type of medicine. You're giving the strongest amount, whatever, this is his first time trying it. You give him the strongest push available, he's going to sleep, he doesn't get any.
That's right. That's right. That is a huge problem that I see, especially in the veterans community. I see tons of vets who experimented with cannabis as a young person, or even, you know, as an adult. They end up having one bad experience with it because they bought something on the black market that's not lab tested. They end up using too much. So that's why this, you know, you guys have such a golden opportunity here. You're creating a regulated market where patients are finally going to have access to a sensible approach of how they can access, you know, lab-tested, purified cannabis that will enable them to start this odyssey, you know, of experiencing different strains and seeing what works for them. But yeah, sure. Go ahead.
So just one other thing I'd like to add is one of the things that we're hopeful to do is we have a relationship with the Hawaii Agricultural Research Center, which is the state's only private agricultural research and breeding organization, the only one in the state. And we've developed a research plan that integrates agricultural breeding with observational studies to identify which strains are having the best therapeutic benefits. These are Hawaii strains from that are local, and then providing that data to HARC, Hawaii Agricultural Research Center, which we have over a half dozen agriculture PhDs available to us to analyze those strains, understand the CBD THC profiles, and try to figure out what is the commonality and start breeding towards that for specific therapeutic benefits. So this is one of the things that we're hoping to do. And the start is having, you know, a really strong scientist, physician like Dr. Sisley to get it started.
I was going to show you guys what we've done here. So when patients are randomized in one of those 4 arms of the study, they have to go through this safety session, right, where we expose them to the cannabis for 4 hours. We have to monitor them to pick up exactly what you're describing. What we expect, you know, the expected adverse events from cannabis, even at low dosages, they might have a panic attack, they might have a psychotic episode, like, you know, feeling paranoid, but those are really rare, right? In truth, under 1% of new users of cannabis get that kind of episode. But the problem is that when they get it, it's so profound that they never want to touch it again. It's just like what you were saying earlier, that nobody wants to come back to it after it. So we want to try to prevent that, but we don't know how. I don't think we're ever going to be able to figure out. One of the things that I try to do, especially if I have a vet that I know is vulnerable to that, you know, if they already have a history of psychotic episodes or anxiety, I usually will opt for a high CBD strain. So phenotypes or strains of cannabis that are rich in CBD, we hope that they will be able to buffer some of the bad side effects of the THC, but we don't know that for sure, but that's the theory. So we try to, usually if you opt for a CBD rich strain, you're gonna end up avoiding some of that, but it's a great point. Someday we'll be able to predict that.
That's a really interesting point about the buffering.
Yeah. To talk about, so that's one of the things that a lot of people have thought is that CBD, you know, we talk about how complex this plant is, right? It's got 138 phytocannabinoids. We were just talking about that yesterday, that NIDA just uncovered the 138th phytocannabinoids. We always talk about THC and CBD, but we got CBN, we got CBG, we got all these, you know, 130 plus other phytocannabinoids, so they all work together synergistically to create what we now call this entourage effect, right? The entourage effect is symbolized really well by the interaction between THC and CBD. The fact that the negative side effects of THC that the doctor was mentioning, the psychosis and the anxiety that are rare, but they do happen, are believed to be caused by strains that are high in THC, like over 20% THC. So when patients get strains that have a lower THC or maybe a 1-to-1 ratio of THC to CBD, the CBD seems to kind of buffer the bad side effects of the THC. So that's how the entourage effects work. The entourage effect works by having all of these molecules working together synergistically, and that's what the gentleman in the back who mentioned pharma, that's one of the challenges we have, is that pharma is focused squarely on isolating a cannabinoid so that they can patent it and put it into pill form and make a lot of money, and that's why it's so essential that we preserve a regulated market, a legal market for whole plant marijuana, right? Because whole plant is where we believe the real efficacy lies. And that's why, pharma has not been able to reproduce the efficacy of the natural plant. And all these, what we've had 30 years now of, fully clarifying that there's an endocannabinoid system. And so pharma has known about this, and they've poured tons of money into trying to replicate the natural plant, but they haven't been able to. So, yeah.
I don't know if this is much a question. I wanted to maybe make a suggestion as
Sure.
far as with these symptoms. You're talking about the anxiety and the paranoia
Yes.
kicking in sometimes.
Yeah.
From anecdotally, what I've experienced is that generally that happens. I think it's a PTSD reaction. They're by themselves,
Could be.
and that's what brings it on in the first place. You get put out of the military, and you're not we anymore. You're I, and I is the most dangerous place to be in the military. And I think maybe it just exacerbates that feeling. Have you guys ever tried doing give them a battle buddy? Yeah, give them a group. Have you ever given them a battle buddy to smoke with? Because I smoke with,
Yeah, that's
when
right.
I introduce people to cannabis therapy, I smoke with them and I help them understand. They're not afraid because they're not sitting there by themselves going, what is this thing going to do to me? Oh my God. They have somebody being like, oh, I can tell this is starting to relax you. I can tell you're starting to feel like this. What is it doing for you? And they talk to me about what they're feeling. They don't necessarily. Have you ever thought about trying that?
That's so crucial. I mean, she's raising a really important issue that I'm hoping folks like Brian, other people, and if anybody here is applying for a license in this, regulated market, I hope that you all hear that, because what we need from, license holders on this island, on all the islands, is to take that seriously, that we need unique outreach with the veteran community that enables them to create opportunities like that. Like, that's why groups like, you probably heard of Weed for Warriors and Grow for, all these different groups are surfacing to try to help vets and do exactly what you're describing, where they create chances for veterans to teach each other how to use the plant. It's better for them to learn from a peer mentor than from me. They don't need to hear it come on down from high from the doctor. They need to hear from each other who've experienced this. I mean, why would a vet trust me to tell them how to use cannabis when I've never even used it personally? Whereas you, who have firsthand experience, are going to be an incredible guidepost for them. So I think that should be taken really seriously, that we need to create environments, and I'm hoping all the license holders will, create veteran support groups and meetings where you guys can get together and talk with each other about that. Yeah.
One of the things that we did is the dispensary location that we've secured here in MOILIILI has an entire upstairs that we're, besides having our corporate offices there, rooms for educational and other types of seminars. Can't do any smoking on site, it's against the statute, so that would have to be done elsewhere. But that's something that we've thought about, to have sort of on-site educational seminars. Another question? Oh, organic.
Yeah. What do you think?
Organic is a term of art. It's a federal label, and so you can't legally, in my view, use organic as a label for cannabis. There are organic-like methods that you can use that we have a goal to use. But until that is clarified, to describe cannabis as organic, I think is misleading. Oh yeah.
Yeah.
So from a pest, of course, I mean this is medicine. It's not just a crop. And I think it was really well addressed in one of the recent committee hearings. This notion that you could grow medicine outdoors is just crazy. It has to be grown indoors, at least in my view. In order to, and when you do that, when you control the environment and you do a really good job of controlling the environment, that should reduce or eliminate the need for any kind of chemicals, or at least substances that, well, everything's chemical, substances that are not natural. So our goal is to only use natural substances for keeping the plants healthy. That was a question about sort of course, we don't want to use pesticides.
Yeah.
There was a question in the back? No?
Oh, yeah.
It's right here.
How many dispensaries are opening in the state again?
There'll be 3 licenses granted in Oahu, and each license can have 2 dispensaries.
Question, because of the stigma, the gentleman in the back, he kind of nailed it. Is there a concern that there won't be enough licensed physicians that can approve a cannabis card for a patient? There just won't be enough.
So the question is what if there's not enough physicians that are willing to certify patients?
There ain't many right now.
Yeah, we're aware of that.
So am I.
And this is why we brought Dr. Sisley out. I mean, it's non-trivial expense bringing her out here and conducting a series of sessions.
Oh, yeah, I love
We've
that.
had over 20 physicians and nurses in each session over the last couple of days. And our plan is to, of course, if we're granted a license, to do this on a regular basis, because conducting education and outreach to the medical community is just as important to the general community, because if we don't have physicians, and I'm going to turn this over to Wendy because she's really the person that should be answering this question.
Yeah.
Come on over here, Wendy.
And
I was just hoping you would mention the bill that's in motion.
I was going to say the bill, yeah.
There is a bill in motion right now
right,
that
there
you
you
could lend support to, and it's so that advanced practice nurse practitioners will be given the privilege of making the recommendations, and that would help us greatly.
Yeah.
So,
And you mentioned,
I think it's House Bill 2707, is that it? Thank
yeah,
you.
and also the educational materials. Yeah.
Oh, okay.
Yeah.
Well, the Medical Cannabis Coalition provides education for physicians and for patients. And the Drug Policy Forum produces a guidebook for physicians who want to make the recommendations. So we try to get that into the hands of all the physicians on the island so that they'll understand what the law is and feel more comfortable with maybe making the recommendations. So I have a bunch of materials back here. You can help yourself to access that guidebook if you'd like to see it. It's outdated now because we got the dispensary bill passed and we got the program changed over to the Department of Health, and there's been other changes, and we're waiting to see what whether or not some of the bills are going to pass to include those as well. So, but in the meantime, you can look at the old version online, or if you contact me, I've created an educational program for other healthcare professionals, and I'm happy to come to wherever you are if you can provide me with a venue to present a PowerPoint presentation. I'm happy to try to educate other healthcare professionals. So please do help yourself to the materials back there and contact me for more information.
Thank you so much, Wendy. So we promised MOILIILI Community Center that when we wrap up, we gotta leave it in the room in the condition we found it. So we have to be out of here by 4. So we want to respect everybody's time. So we have about 10 more minutes, and then we're gonna wrap up. So are there any more questions for Dr. Sisley, myself, Wendy, I don't know if Chris Garth from the White Dispensary Alliance is here anymore. Question?
I would just like to encourage everybody who hasn't seen the 2016 Cannabis Health Summit, all the nice videos that all the doctors spoke about, you can check it out on YouTube.
There you go.
And
Good
especially
idea.
like Dr. Dustin Sulak, I believe his name was, and talked about how if you're smoking the same medicine, perhaps you have a panic attack even with that same medicine, so really be aware of that. And so if anybody wants to check out the Health Cannabis Summit.
Health Cannabis Summit 2016.
Very good.
Thank you. Any other questions?
That's it.
Going once? Going twice?
You mentioned earlier, I just want some clarification on non-edibles, and I know since you switch over to the Department of Health, they don't condone smoking, so what?
Yeah.
So, the flour will be can be flour and oils. The smokable materials can be sold. Our understanding of the rules are that the smokable materials can be sold, such as oils and not oils can't be smoked; they can be vaporized, and the flour can be sold, but no.
Concentrates and flours.
Concentrates and flours and oils are all allowed, but no, well, the legal term, I don't like using it, no paraphernalia. So no vaping pens or any other materials, equipment that can be used to smoke or vaporize can be sold in the dispensary. My response is to support the legislation that's currently being heard. HB 2707 just got scheduled for the Finance Committee, I believe this week or next week. You can submit legislation. I don't think verbal testimony will be taken. And then it should hopefully, not would, cross over to the Senate, and you'll have additional opportunities to provide testimony. That's the solution. It's not going to happen in this room. Any other questions? Yes.
I want to kind of go back to my original question, what I heard you say in terms of accessing information. What I think I heard you say was the hard science research is yet to be done.
Yes.
And if you're trying to figure out what you're doing, that you're kind of on your own.
Well, on your own with consultation from these facilities now. That's what we hope, is that you're going to find that the medical people who are available on site here are going to have at least they're trained in the medical model, and many of them will be experienced in cannabis and how to, so hopefully they'll be able to guide you. It's not going to be complete blindly,
In terms of self-education, where do you go for those credible sources of information?
Yeah, that's a great question. There's a few different sources. For medical, I usually go to, if you guys have seen Americans for Safe Access, they have a really good website where they've compiled all the the peer-reviewed research articles under each different condition. So you guys can, they've done a good job of compiling that. On the website is, I believe, safeaccessnow.org. And so that's a good place to start. And then, of course, do you know of any other one?
There's one called the Granny Storm Crow.
Yes, that's right.
That thing's like 800 pages long.
Yes.
It's the Granny Storm Crow.
Granny Storm Crow, she said.
Subdivides them by conditions. You can actually go to your condition and you see like a whole list of just clickable links. You go to different clinical trials and actually find it by condition.
That's right. Yeah, if you Google Granny Storm Crow, and it's not all peer-reviewed articles, but it's still an incredible resource. I can't believe somebody did that.
Good question in the back.
Yeah.
Granny Crow. I don't know where she's
Anybody else? I know, right?
All right, go ahead.
Marijuana is bad. Very few people have tried it for illness that you're considering. But once dispensaries start opening up, you start getting in there, trying the product, and find something that works, you can talk to people while you're in there.
Yeah.
Yeah.
What are you using it for?
Exactly.
That's the only way you're going to have a
It's a good point.
It's sharing with each other.
Yeah. Yeah, another benefit. Anybody else, or we should let you guys enjoy the rest of your weekend? Should we do that? All right. You guys, thank you so much. Thank you all very much.